So now I'm going to do a case study, because everything you've learned individually, like the assessment scales, like rehabilitation, like swallow screen, like thrombolysis, but it all goes into one person. So your brain has to be thinking not in sections, but as a holistic entity when you're looking at after a patient. So you can't sort of go down a tick list almost. So what we've got to then do is bring it all back, all these little elements that you've learned back into one person. So I'm going to just do it. It's going to be an acute section, just a section of a person. And again, I want you to respond, and I want you to actually think about some of the questions I'm asking you. Okay, so this is a gentleman. You're in pre-hospital, you're in the ED department, and an ambulance service rings the red phone at 10:30. You are the nurse that answers that phone. They say they are bringing in a 55-year-old male, history of diabetes and hypertension, was fit and well at home according to his wife, and then the symptoms started 40 minutes ago. They're suspecting a stroke. The ETA expected time of arrival is in 15 minutes. What are you going to do? What's your first actions? Yeah. So let's think. These are just some suggestions I would think when I was thinking about it quickly. I'd inform the acute bay manager, because depending on how your ED is set up, you want a bed or a trolley ready with all the equipment on it, ready to go as soon as this ambulance rocks up. Yeah. You want to make sure that there's an empty trolley. You alert the stroke team. You're giving them, by the time you get hold of them, you may have 12 minutes, 10 minutes left. So you're going, there is a suspected stroke in the window time, ambulance have pre-alerted us. Can you get down? So somebody can be already on their way. They can literally meet them on the door. You warn the CT scan, depending on how many CTs you have, especially lots of them have only one CT scan. You want them to free it up. So if they've got a patient and they can finish, or if they're about to take another patient in, you hold it back. Keep the CT scan empty, ready to roll. You allocate a nurse, if not yourself, to receive the patient. And that's important because you're giving them the brief to take over that responsibility. And then you can actually ask them, and you can see if it's possible to directly transfer to the ED room, CT scan room. Some ambulance crews believe in your countries, and no, in Qatar, our ambulance service believed that they had no right to go straight to the CT scan, and they had to drop the patient in ED. And yet when we spoke to the ambulance bosses, they went, no, it's not a problem, we'll just change it. Which meant that the ambulance, you don't unload a patient onto one trolley to unload them off the trolley into a CT scan. You take the ambulance trolley straight through. So it's worth thinking about how you do that, right? So within ED, you do a quick examination, right? This is eyeballing a patient just quickly. Right arm movement against gravity, but hits the bed quickly. Right leg movement against gravity, but hits the bed quickly. He has partial facial droop. He has slurred speech, but is understandable. He has mild to moderate sensation loss. Right? You've got him into the CT scan, and his CT scan looks normal. Time now is 11:15. What do you require? Do you require any further information? What other information would you be asking at this stage? What is his blood pressure would be a good one. Is he suitable? Because he sounds suitable for thrombolysis, but then you have to start thinking about the others, don't you? So what is his blood pressure? What is his blood sugar? Is this a hypoglycemia attack? What is his weight? Because if you're going to give a drug that's weight specific, then you need to know what his weight is. And can he give consent? Is he conscious enough and able enough and aware enough to be able to give his own consent for treatment? Or is there a relative around that you need to speak to? Yeah. So you may come up with other sorts of things that you need to think, but they're the things I thought of when I was just doing this. Further results then. So his blood pressure is 190/95. His blood sugar is 5.2. The patient says he weighs 106 kg. He's a big gentleman. And his wife has arrived in A&E. Patient can understand. He's got slurred speech, but it's understandable. And he is alert and answering questions correctly. Okay. The doctor is keen to give thrombolysis. Come on, we're on time. Come on. You know, will you give? Or this, the doctor is literally saying to you, draw it up. I want to give it. Are you going to say something? Or are you going to just follow the doctor's instructions? Please say something. What is his blood pressure? What are our levels of blood pressure before we should treat? Yeah? He is over the 180, 185, so it needs to treat it. Blood pressure needs to come down. Patient can give his own consent, fine. But you need to think about this. So you need to say to the doctor, please, just check his blood pressure for me. Blood sugar's fine. Yeah? So you give labetalol 10 milligrams and calm the area down. It's amazing when everybody gets really excited, especially if you don't do thrombolysis a great deal, everybody wants to be in on the act. And this poor patient is swamped by people. And anybody that gets anxious, the blood pressure is going to go up. So you need to calm the area down. Send people who don't need to be there away. Calm it down. Calm the patient down. And it's also an option to explain to his wife and the patient why you're doing this, okay? Because you have to wait for that blood pressure to come down a little bit. So you can explain to them what the drug is about. You're not asking for consent, but you can start that conversation while the doctor is doing other things. You can be there explaining why there's this panic, why there's this rushing time. It's because the drug has a limited window, and the quicker you can give it, the better the opportunity of recovery. Okay, so you can start explaining all that. Now the blood pressure is down to 170/90 because you've acted on it, you've given medication, you've calmed the situation down. Good to go? Great. So it's now 11:30. He's been in ED since 10:45, I think it was, he arrived. So we're all on time. We're in plenty of window time, taking its time to get through. And the doctor makes the decision that yes, let's give CPA. And he prescribes 95.4 milligrams of actylase. That's 106 times 0.9. Great. How much are you going to give as a bolus and how much is it of an infusion? And are you happy to give? Are you happy to give this much? What are the rules when you're looking at it? We're saying 0.9 per kilogram of weight up to a maximum of 90 milligrams. Yeah, that's 100. So you're going to say to the doctor, doctor, can you please re-prescribe 90 milligrams? And then you're going to give 9 as a bolus and 81 as an infusion. Yeah? Please do not give the 95.4. Everybody gets into a panic. Mistakes are easy to be made. And everybody's aware that it's 0.9 per kilogram. And it's very, very easy to forget. Okay? So 2 brains are much better than 1. So use the doctor's and your own. 11:40, sorry. Prescription amended to 90, bolus 9, infusion 81. Bolus was given 11:45. That's 110 from onset and 55 minutes from the door. That's really good. Could get better, but it's another 60. It's a good start. Yeah, so what now? We're going to run into the blood pressure, aren't we? It was high. The chances are it could start creeping up once the labetalol has worn off, and you may need to give more. So who's responsible? And you have to be careful, because once that needle's gone in and the infusion started, the doctor's walked away. Yeah? So we have to keep an eye on it. Record all actions so far. Now, this is the time when you're monitoring the blood pressure every 15 minutes, but you can catch up with your notes. Catch up what you've given, catch up when you gave it, catch up what the symptoms were, do your notes. Don't fuss. This is a very English term, sorry. Just as I say, calm the situation down. You know, get a chair for the wife, sit there monitoring him, the patient, but, you know, let it all calm down. That will help keep the blood pressure down. Once the infusion is completed, you can start the swallow screen. And there is no need to do anything. I mean, if the patient is in his own clothes, there's no need to start undressing him, put him into gowns or anything else while the infusion is going on. Just leave the infusion to be completed. It's an hour. That's all it is, an hour. That's for blood pressure monitoring, yeah, quarter hourly. Just let him be. If he's sitting on a chair, let him be. Once it's finished, you can start fussing him. So you can then do the swallow screen. Yeah. At 2 hours, you can do the NIHSS, and then you can report to the doctor how the patient's doing and the blood pressure control. At 2 hours, his speech has improved. There is minimal facial droop. His right leg movement against gravity, but it hits the bed. So that's the same as when he came in. But his right arm has drift, but doesn't hit the bed now. So that's an improvement. And he still has sensation mild to moderate loss. Okay, so he's got minimal facial droop now instead of partial, and his speech has improved. So he's definitely on the right track. Yes. Now what? Now what we're going to do? And although I can't all talk to you and see you, get you to answer me all, I hope you're thinking about what you would do now. What would your actions be next? My suggestions: admit to a stroke ward if you got one. It'd be much better to be nursed. As they say, 18% of people get better for purely being on the stroke ward other than any other reason, because you have nurses who know how to care for you. Get the physios and the OTs involved early rehab. Look for what might cause the event. So this is going down the doctor's line, but that does not mean to say you already know he's got hypertension or he came in with hypertension. So you need to start looking at that and monitoring it and assessing it, yes, and reporting to the doctors what the results are so they can start treating and getting it under control. Explain to the patient what he needs to do to help reduce a second event. Nurses are much, much better at teaching patients than doctors are. Doctors' heads are so full of diagnosis and what they need to do, and they are so brilliant at all that. But actually giving patients time to sit and just talk through at a very basic language, some fail. Some are brilliant, some don't. Nurses always have, the vast majority of nurses, shall I say, have that ability to sit and talk and teach. And that's what you need. So what I'm saying now is keep calm and stay healthy. And as I'm now working in a Nightingale hospital in England with all the COVIDs, you need to be careful. Take it calm. Thank you. But for now, I will start with the assessment scales that we use within the stroke service. We all know FAST, yeah. What does it stand for? Face, can they smile? Is it equal? Arm, can they raise both? Are they equal? Is one going down? Was one lift and then drop? Speech, can they speak? Are they making sense? Is it slurred? And if any of these signs are there, it's time to get help fast, because it's all about time is brain. Yeah. So it's important that you teach this, not just to your staff, but to everybody in the community. This is the start point, because if the community doesn't recognize when a patient's having a stroke, they're never going to get into you to be able to do anything about it in the hospital. So we start with a TIA. So what is a TIA? Transient ischemic attack. It's caused by artery-to-artery emboli, and it can be a plaque or it can be cardioembolic. So it can come from the neck or it can come from the heart. But because it's temporary, it's only there for a while. So it goes very quickly and it can last only for a few minutes, and there is full resolution. If it goes, but the arm is still weak, then that is not a TIA. It has to be full resolution. It has to go back to completely normal, which means that what you're having to look at is the history. You have to base your diagnosis on the history. And it used to be a very throwaway diagnosis, in the fact that many doctors would go, oh, well, it sounds like it could have been a TIA. Never mind, it wasn't a stroke, go away. The problem with that is that TIAs are a warning shot that there could be a stroke happening in the future. And many people go home and think they've had a TIA, and it makes them very frightened, because they're thinking, I could have a stroke any minute now, or in the next week, or in the next month. And it can destroy lives. It is not a throwaway diagnosis. It's something that should only be diagnosed when you really think this patient has had a TIA. And you can see why these people get so frightened, because you can go onto Google and you can look up these figures, and you can see patients who have had a TIA, how their risk of having another event or a stroke is as high as if they'd had a stroke. So we look at something called the ABCD2 score, which is a risk calculator that was formed in Oxford, and it's been well tested and in thousands and thousands of people. Slight point is it's a Western tool. And one of the risk factors is age greater than 60, which is great when you're living in a country like I am now, where the average age of stroke is 77. But in Qatar, the average age of stroke was 54. So you have to sort of look at this as an assessment tool. Yes, don't take it black and white. You might decide actually not to worry about the age, or you might to think, well, the age, if it was 40, in countries where the age is a lot lower, the average age of a stroke is a lot lower. But then you've got the blood pressure. So you've got systolic blood pressure is greater than 140, or the diastolic is greater than 90. You get a point. So you've got the patient in front of you, his blood pressure is way up, you've got a point. Then you look at the clinical features of a TIA. Was there unilateral weakness, one-sided weakness, with or without speech impairment? So if it's unilateral weakness, you will get 2 points, with or without speech. You don't get an extra point because you've got speech as well. It's 2. And speech impairment without unilateral weakness, you get 1. Any other features, you get 0. And then duration. Did the TIA last longer than 60 minutes? Is a 2. If a TIA is lasting longer than 60 minutes, you will often find evidence of the stroke on an MRI. So, you're looking in that area. TIA duration between 10 minutes and 59 minutes, you score a 1 point. And these, don't forget, are completely resolved. And then you've got diabetes. So diabetes, as we know, causes major problems with lots and lots of organs. So poor old diabetics get 1 point just for being diabetics. So you can see you could be scoring 2, 4, 5, 6, 7. So 7 points for a TIA. You got that? A, B, C, D, D. So what I want you to look at now is a case study. And we're going to use that tool to risk stratify this patient. Okay, so he's a 72-year-old right-handed man, background of diabetes and hypertension, presented with 55 minutes of transient inability to speak and right arm weakness. He was brought into ED, and by the time he was brought into ED, everything had resolved, completely back to normal. His blood pressure was 160/95. He's not compliant with his diabetic or his hypertensive medication. So what would you score this gentleman as, thinking about the previous slide? Ahmed, can you just give me a range of figures if they've put it in? Yes? Okay. Let's go through this then. So how old is he? Age. Age, he is 72. So he scores a point over 60. He is diabetic. No, let's go through it, sorry. Blood pressure, what's his blood pressure? 160/95. He gets a point, right? C, clinical features. Unilateral weakness with or without speech. Well, he had weakness and he had the inability to speak and right arm weakness. So he scores 2. So we're on 4. D, duration. He was 55 minutes. Yeah. So he scores a point. That's 5. And then he's diabetic. So we're scoring a 6. Yeah. So did everybody get a 6 on him? Next one. "56-year-old lady, previously fit and well, no known chronic medical conditions, came into ED department with a 10-minute history of not being able to speak. On taking the history, she also mentioned a previous episode the day before of right arm weakness, but it only lasted 5 minutes. Her BP in ED was 138/56. Her heart rate was 80 and her temperature was 36.5. So can you score this lady? And what do you think? Is she a low risk or a high risk? Okay, so let's go through it again. Now look at this lady, because she's quite interesting. She's actually had 2 episodes, hasn't she? So she came in, and we'll take the first one. So she came into the ED department. She's still 56, whatever. So age, she doesn't score anything, 0. Okay. Blood pressure, and we'll say for argument's sake, it's the same first time and the second time. So it's 138, she scores nothing. Okay, 0. So then you're looking at C, right? So what are you looking for here? Let me see if it goes through. There you go, that's easier. So what you're looking for is clinical features. And the first time you're looking at, she's not able to speak. So she would score a 1, okay? And it lasted for 10 minutes. So if you were generous, you'd say 2. She's not diabetic. So you would say she was scoring a 2. But she had an episode the day before. She's still 56, so it was a 0. Her blood pressure is still low, so it's 0. Her clinical features was right arm weakness, so she would score a 2. Her duration lasted 5 minutes, so she'd get nothing. And she's still not diabetic, so it's not. So each episode on their own would only score a 2, which is low. But would you consider her to be low or high risk? I would consider her to be high risk because she has now had 2 significant episodes, one day after another, which means there is something going on in those arteries. And if we don't deal with it and find out the cause of it, the next one she has could well be a stroke, a clot in the artery that doesn't move on. And she could end up with significant damage at 56 years old. So she would be a very high risk patient. If she turned in ED, I would not be sending her home from ED. I would be admitting her and investigating her very quickly. I'd want to know what her arteries were doing. I'd want to know what her heart was doing before we'll ever let her home. Okay. So case 3. 45-year-old female, no chronic medication, presented with a history of a sudden loss of consciousness for a few seconds. Previously, similar episode 3 years ago, and was told it was a TIA. Her blood pressure is 135/70, and her random blood sugar was 5.6. So, fine. So what do you think with this one? Go through it again. A, age, 45, no points. Blood pressure, 135/90, no points. Clinical features. She presented with a sudden loss of consciousness for a few seconds. Sudden loss of consciousness, no weakness, no speech development, 0. Duration, a few seconds, 0. Diabetes, 0. Yeah? So she would have scored a 0. In fact, would you say this was even likely to be a TIA? And should she have even been referred to the TIA clinic? I mean, a sudden loss of consciousness. There are very few strokes I've ever come across who completely lose consciousness and then get up and walk in 3 minutes. Doesn't happen. It's more likely this is either cardiac or a faint, simple vasovagal attack. But here again, she's been told that 3 years ago, because of an event like this, it might have been a TIA. And therefore, she has the worry that this time it could be the stroke. Yeah. We move on now to the modified Rankin score. This is a good way of defining how the severity of the stroke is. And one of the reasons we do modified Rankin scores is because it is international. And if you learn how to do it properly, you can then judge yourself and your centre against any other centre in the world that does the modified Rankin score. And then you can see how better your patients get from rehabilitation, or if what your service is doing has no effect on the outcome of a patient at all. So you would want to know if a patient had come in and was severe in a stroke, that the severity of the stroke had improved. Yes? So it's very simple. It's a scoring system from 0 to 6. 0 is completely normal, completely fine. 6 is dead. So basically, you only have to worry about the 5 in between. So 1 is no significant disabilities, can carry out all usual tasks. Yeah. No significant. 2, slight disability, unable to carry out all previous activity, but able to look after themselves and their affairs and without assistance. Moderate disability requires some help, but able to walk without assistance. And those are the categories you want your patients to get back into, because after that, it becomes more and more disabled. And we know stroke causes the second rate of disability in the world in adults. So it's no use coming with new techniques and new treatments that are going to stop people dying, but just put them into the bedridden zone or the severely disabled zone. So everything, all the drugs and everything else and the research is all geared to getting their patients back into the 1, 2, 3 category, where they may require some help, but they're able to walk and they're able to function, and life is worth living. 4, moderate severely disability, unable to walk without assistance, right? Unable to attend to their own bodily needs without assistance. And 5 is severely disabled. So they are bedridden, incontinent, requiring constant nursing care and attention. And that, for a lot of people, is actually worse than death. So, you know, as I say, we want to get them into the 1, 2, 3, well, 0 to 3 range. And it's very easy to do this score system if you ask a simple questions, and you can actually do it on the phone call. So, you know, a year after the stroke, you can phone people up and say, can I ask you a few questions? And if you answer them through, you can then see where you're up to. So could you live alone without help from any person? This means being able to bathe, use the toilet, shop, prepare all meals, cook, and manage your own financial assistance. Okay. So if it's yes, you're going down the less severe disabled route. So can you do everything that you were doing before, right before a stroke, even if it's slower and not quite as much? If it's yes, you go down this column. If you know, it's a 2. So if it's yes, you go down this column. And are you completely back to the way you were right before your stroke? If it's a no, it's 1. If it's a yes, it's 0. So that's the simple ones. That's getting you into the good group, yeah? If you go back and you say, no, I can't live alone, I can't manage everything, it's a no, then you go down the other route. Can you walk from one room to another without the help of another person? If it's a yes, it's 3. So if you need to get a quad stick or a walking crutch, and you can walk physically and mentally from one room to another without any help from anybody else, then it's a 3. If you can't, it's a no. And then it's dividing it between 4 and 5. Can you sit up in bed without any help? So can you reposition yourself? Can you get yourself up? Could you eat in bed sitting upright? If it's a no, it's 5. If it's a yes, it's 4. You got that one? I'm going to ask you the questions now. You've got to talk to these patients through. So, case 1, 60-year-old gentleman. Prior to a stroke, worked as a driver. Suffered a left middle cerebral artery infarct 3 months ago. Caused aphasia, so he couldn't speak. Right arm and right leg weakness. Initially, his NIHSS was 5, which is another scale that I'll show you later. Transferred to rehab, his modified Rankin score of 4. Now, what did we say about 4? We said a 4, he could sit up in bed. without any help, but that was it. He couldn't walk unaided. No? Now, limited speech, sensation loss on his right side, still weak on the right side, his NIH is 7, but he's able to walk with a stick. So what do you think his modified Rankin score is now? Yeah? So we know he can't look after himself fully and he's still got weakness. So we'll go down the no route. He can walk from one room to another without help. So he would be a 3, which is a big step. I know it's only one number, but it is a huge step in this gentleman's life because he now is put into a point where he can actually look after himself for some time. He can walk from the one room to another. He can get himself to the toilet, which is a huge leap in this gentleman's lifestyle and quality of life. Case 2, a 50-year-old piano teacher presented with a lacunar infarct affecting her left side. She made a good recovery and was able to walk independently and drive. She has returned to work, supervising the class, not playing the piano as the finer movements of her left hand remain a problem. So what are you going to give her? What do you think she scores? If you look back at the screens. So she can manage and look after herself and get her own meals and finance and drive. So we're going down this lane. She cannot completely get back to normal, can she? Because she can't play the piano and she was a piano teacher. So that's a major issue for her. So she's a 2. Yeah. Okay. What about this gentleman? 60-year-old gentleman with diabetes, hypertension, end-stage renal failure, suffers a middle cerebral artery stroke affecting his left side. He is unable to care for his ADL, so he can't look after himself, he can't wash himself without assistance and is mainly confined to his bed. With some effort, he can sit himself up to feed himself. So, where are you going to put him? What are you going to classify him as? Well, so he can't walk from room to room. So we're still going down this route. Can you sit up in bed without help? Yes, he can. Okay. So we're going to give him a 4. Sorry, I have to keep going backwards and forwards so I can see it. Yeah, a 4. So you can see how the difference is. And sometimes they are subtle differences. And if you don't do the training on the modified Rankin score, you might score it differently or go, oh, well, he needs a stick. Actually, I'll give him a 4. Where actually, no, as long as he's got a stick and does it himself, he's fine. He's a 3. And you can see how important it is because this is the research that comes out. So intravenous therapy alone, and you can see 6, don't forget, is dead. Yeah. And then you look at intravenous therapy and thrombectomy, only 15 people are dead, which is really good. Saying, wow, 50% reduction in death rate, but it's not worth it if all you've done is tipped people into the severely disabled brackets. So what you have to look at is the first 3, yeah, so from 4 upwards. So you can still see there is benefit from TPA and thrombectomy. Yes, so you can still see from 12, 15, 12, 5 and 15, so what, 2032 versus 37, 47, 51, right? In those 3 categories. So there is a huge, still a big percentage of patients that would benefit from that. And this is a website you can share, and you can, I'm sure they will put it up again at the end, but it's the http://rankinenglish.training campus It is a free website, and you can go on and you have to go through the scenarios and you have to pass all the scenarios. And although you may think you've done this video before, it's often a different subtle turn on the video. So don't skip past any of the videos, okay? And you need to score each one and you will get a certificate. It is worth doing, and it's good for your CV, it's good for your career. So see that you've done those things. So please have a look at that one. Bamford classification is a very much, it was introduced again in England, but we use it very much more nurse-wise. And we do it this way, and you'll find lots of the nursing papers that are written over here have this, because it doesn't rely on a CT scan. It doesn't rely on which part of the brain is affected. It puts them there, but what they're looking at is the clinical damage that's done. So we are looking at it from a purely patient's level. So you're looking at, we call it tax, packs, pox and blacks. So total anterior circular stroke. So stroke means it could be an infarct or it could be a hemorrhage. Okay, doesn't matter which, because they have the same outcome on the body, the same results on the body. It's a partial anterior stroke, which could be again infarct or stroke. You've got a posterior circulatory stroke, and you've got a lacunar syndrome. Yeah. So it depends on what you've got, and there's three things you're looking for. So a total anterior circulation, you will have, because you're talking about the whole side of that brain. So you're looking at unilateral weakness, okay? You're looking at homogeneous hemianopia, and you're looking at higher cerebral dysfunction, which is the dysphasias, aphasias, visual perception sort of thing. If a patient scores 3 of 3, they're a tachy. If you then get a CT scan, it says, oh, it's an infarct, you can say tachy. If it comes back as a bleed, it's tach with a H on the end, okay? For a partial anterior circulation, there should be 2 of 3. So do they have weakness and homogeneous hemianopia, or weakness and speech difficulties? 2 out of 3. Posterior is a little bit more because it's cerebral, so you could get loss of consciousness, you could get isolated homogeneous hemianopia, so you get slightly imbalance, those kind of things. And then you've got lacunas, and the lacunas can vary, but they're pure sensory stroke. They can be ataxic hemiparesis. So it's where, depending on where the lacuna affects, you'll get the different results. And the important thing of that is you don't have to, especially from nurses, and it doesn't stop you writing. It's a really good way, because nobody's going to say, oh, well, can they do a CT scan? Can they interpret a CT scan? We're looking at it from a patient's point of view, and we're looking at it at outcomes. And if the patient has an arm and leg that is dysfunctioning, then you can put them into the categories, and you can see that the research that's been done is prognosis at 1 year. So like the total anterior circulation, 60% die, yes? And only 5% are actually independent. This is without treatment. So, and then recurrent in 1 year, 5% will have another. 35% are dependent. And it goes that way. 15% die of partial anterior circulation. 55 can get back to independence. So these are the moderate ones in the middle that are really, really worth the effort to rehabilitate them. And then you've got the lacunas. Only 10% die, but 10% do have a recurrence in a year, and only 60%, not all of them, get back to complete normality. And again, with the POCIs, 50% get back. So, it's worth looking at, and it's one of those tools I would suggest for nurses to really look at if you want to do papers and you want to write about stroke patients and your outcome details. It's a good one. The National Institute of Health Stroke Scales. This is the NIHSS that we talk about, and it's really good to have a common language. And anybody working in stroke and caring for stroke patients really should have the certificate to be able to do this one. And again, I would say a certificate because you need to be able to score it and know that what you're scoring is exactly the same method of scoring as the person in America doing it as well on a different patient, because then you can compare your kind of patients to their kind of patients. And this goes for doctors as well, that if they're going to do an NIHSS, they need to have done the training, because some of them are very subtle and you need to know what you're doing. So nurses, physios, OTs, speech and language, the A&E department, the doctors, or anybody who wants to can go online and do the training. It is a video, it does go through, it takes about 3 hours, and then there is a test, and you have to get 85% or more to pass the test. And you have to do it each year to stay abreast of it and to make sure that you haven't allowed your knowledge to slip. Yeah. So that's what I've been talking about. And this is it. This is it that goes through 0 to 45. Now, when you know it and you know it really well, when your stroke comes through that front door and you're concerned about door to needle times and getting the patients, you know it well enough to go, oh, facial palsy at a glance. Down the corridor, you can see facial palsy, left-sided weakness, over to one side. And you get up to them and speak the first few words, you know whether they've got ataxia. Once you've got that, so you can score them very quickly on a number of issues. And then you'll be going like, okay, no movement in the arm, no movement to the leg, that's 8. That puts them in the category for thrombolysis. So you get to CT scan, you get going. Yes? When you have time afterwards, you look at it much more closely. And often people miss things like extinction neglect, where if you press one side, they can feel it. You press the other side, they say they can feel it. Press both together and they can only feel one side. And people don't do it, and they don't do the visual ones very well as well. So you need to go through this carefully and at length to get it through. And this is the training site for this one. And again, it is free. And you can do it from anywhere in the world. And it is important that you do it. You'll get a certificate again, and it's good for your career as well. And it's good for talking, because I can say to a doctor, okay, we've got a new gentleman coming through the door. He's at 45 minutes from the onset of symptoms and his NIH is 12. That's all I need to say. The doctor's on his way. I don't have to describe anything else. So it's a very good shorthand communication. Also, I can say this patient, when he arrived in, was scoring 15. We gave him thrombolysis, and at 2 hours, he was down to 11. The following day, he was down to 7. And people know what I'm talking about. Yeah? So it's a very good shorthand way of talking as well.
I hope everybody can see the screen. Okay. So I'm going to discuss 2 cases. It's from rehab perspective. Mrs. D is a 45 years old young home manager admitted to the hospital with right ACA infarct. She's been on medication for hypertension and diabetes for the last 5 years. On examination, her NIH was low, just 2. Everything was normal except right upper limb power, which was 4/5, and she was having some subjective numbness. On day 2, she requested for discharge as her school-going children are at home. So on urgent basis, investigations were carried. And at the time of leaving the unit, the assigned nurse noticed that the Mrs. D is unable to follow the instruction. The nurse was asking her to write down the medication timing, which she was unable to. On inquiring further, she's a postgraduate. She was the one helping the kids at home to do the homework. So this is not something usual with her. Moving forward, moving forward, can she be allowed to go home because she's already working? She has subjective numbness and her power is almost normal. Does she need any assessment from anybody? Does she need further assessment from occupational therapists? What is the actual problem she's facing? And if she is having any problem, what type of rehabilitation program you recommend? So the therapist was called and he said he's having dyspraxia. Dyspraxia is a partial problem with planning, coordinating, and performing any skill which is already been performed by the person. Apraxia is a problem, a complete problem of the same. Dyspraxia, where the patient is having a partial problem of the same component. So this person, she, for example, if she wants to make a um, make something, she will know what all to be collected, what to do, but she will not be able to do it step by step. She will not be able to plan it like what to do first and what all to be collected, what is a step for completing the task. So how do we treat it? So what was done once the therapist evaluated and they identified that the patient is having dyspraxia, although it seems simple, it's not simple actually. If she is the one who's going to do all the tasks at home, especially cooking, then she's at risk of having injuries to herself. So, how does it manage? So, the person who's treating the patient need to understand that this problem is not new to the patient, and the person might not understand it's what is the actual problem. Need to be very patient in making them understanding and to helping them do the task. One task need to be done at a time. Like first thing, gathering all the needed items, and then second step, cutting all the vegetables. One step, one task or one simple thing need to be done at a time, and breaking it into different component will make it easy for the patient to understand. Starting something simple other than, like for example, in cooking, instead of asking the patient to make a complicated dish, if we start with a simple one, that is first thing to make sure that the patient is understanding. Second thing, to confirm that the patient is able to organize and do and complete the task. And very importantly, to make sure that the patient is safe to be left alone or to complete the task. Sometimes, even on the simple task, they need to be supervised or helped continuously and repeatedly. So there is no limited number of times that the patient need to be trained. The, mm, the final goal is to make sure that the patient is safely doing any task and encouraging at every stage when the patient does correctly, encouraging to do more or encouraging or appreciating what the patient has rightly did will help the patient to achieve the goal. And it's very important to make sure that patient is safe, the environment is safe, and safety of others as well. So, what is the post-discharge care needed for this patient? Initially, once the patient is discharged from, or the patient needs to be under supervision. Even Simple tasks should be supervised at home, safe environment to be maintained, and any modification is required. Like, for example, if the patient has to take hot water from kitchen to the dining table, which is far away, then if patient still has problem with planning and coordination, then it's going to be a risk. So this is case number one. And case number two, Mr. P is 31 years. He was admitted to the hospital with left basal ganglia bleed. He is hypertensive, not on any medication for the last 2 years. He's a plumber by profession. When he was admitted, his NIH was 18. He was having right dense hemiplegia, aphasic, confused, and he was having neglect as well. He was admitted to the ICU. He was in ICU for 10 days, and now he is on the ward. So the on day two, the patient was evaluated by the therapist. The nurse said the patient is having low mood, and the therapist said patient is hemiplegic. They tried sitting the patient on the edge of the bed. Patient was having poor trunk control, poor sitting balance, and patient was aphasic, was not able to follow commands consistently. Basically, the participation was considered poor. So the therapist said, patient is still a candidate, will eventually be a candidate, rehab candidate. So what are the reasons that the therapist is saying that the patient is still can be a rehab candidate? Because he's only 31 years, he's young. And we know the reason for this bleed is hypertension because from the previous slide, we heard that he is hypertensive, not on medication for 2 years. And all these confusions and less participation and low mood could be because he was admitted to the ICU for 10 days. So the therapist said he will eventually be a rehab candidate. Let's wait. But what the rehab doctor said is he's not suitable. He could go to the, he is maybe later he can come to the rehab, but not now. So the reason for him saying is NIH is 18. We said 6 to 18 is the clear cut criteria for inpatient intensive rehab. Patient is having aphasia, so there will be problem with understanding and participating in therapy. Patient is confused. Patient is having neglect. And patient was in ICU, which means initially patient needed intensive care. So altogether, when it is looked from outside, patient is not a candidate for active intensive rehabilitation program. So, and the rehabilitation center also refused accepting him as an intensive care candidate. So they said the patient, maybe because his participation is going to be poor, because he's not following commands, because of the from the NIH and from his initial admission in ICU, you know that it's a large bleed and the improvement is going to be slow. Most of the hospital, even the rehabilitation centers, they have limited number for stroke patients. They might have more beds for other spinal cord problems and trauma, but less number of beds for the stroke patients. So they might think that patient will, with this clinical condition, patient will end up staying in the unit for a long time, which is going to affect taking other patients in. And the other problem is if patient's condition does not improve, even with therapy, where are they going to discharge the patient? So it's going to take a lot of time and energy from their point of view. And the patient's potential complication is high. So these are the reason for the rehabilitation center itself to refuse taking him. So what did they do? So everybody together, the MDT sat and they decided, okay, let's give intensive therapy for 1 to 2 weeks in the same ward, acute setup, so everybody can monitor him. And as a team, decided to review him every 3 to 5 days to see if there is any new problems or is he improving. Is there any point in keeping him for 1 to 2 weeks, expecting that he will be a rehab candidate? And the whole team together decided to review him after 2 weeks after the intensive therapy. And they decided if no improvement, then they will move him to the slow stream, which means the patient will be given therapy, intensive therapy. And once the patient improves and ready to be transferred to the inpatient intensive rehabilitation program, then patient will be accepted. If there is no improvement or if the patient has deteriorated or progressed with any of these deficits, then the patient will be pushed to the long-term or skilled facility. So that was the decision. So what happened? For 1 to 2 weeks, the regular therapy was given. Everybody were actively working with them. Patient was screened for depression. VT prophylaxis he was on. Other supportive care, blood pressure management, and prevention of complication was carried out. Patient slowly started improving. Um, Everybody together reviewed him after 2 weeks, and rehab accepted him for intensive rehabilitation program. I hope you have understood the criteria for accepting patients to the intensive rehabilitation program and how patients, even from the intensive rehabilitation track, how patients can go out if there is deterioration in their status, and how patients can come in if they improve clinically. So, but the important thing is at that point of time, if during that stage, if patient develops any complication, then the patient might not end up in rehabilitation. If the patient is cared as a whole, considering everything and understanding, taken care by a skilled nurses on the stroke ward, patient can still be a rehab candidate. The conclusion is like the first case, vision and perception deficit also affects uh, daily living, and it can also affect quality of life like any other motor deficits. No patient should be excluded from rehabilitation unless the patient is too ill or there is no chance of improvement because the patient was already uh, having the same functional status. This is my reference, and thank you for listening to the presentation.